Okay, good evening, everyone. Thanks for joining us tonight. My name is Dr. Sydney Kapp. I'm here with Specialty Eye Care Group. I'm one of the pediatric and binocular vision doctors here. And tonight I'm going to be talking a little bit about optometric light therapy, or Syntonics, as I think a lot of you know it as, and just how we kind of use it at our office. It is something new to this office. I first got introduced and interested in light therapy in my residency program, and it was used pretty often in that clinic, and I saw a lot of great results with a lot of the patients there, and I thought it was kind of another good tool to have in our toolbox over in our vision therapy department. So I brought what I know about vision therapy and tailored it to how we want to use it at this clinic. And I'm just going to tell you guys a little bit sort of about what it does, the history behind it, how we test for it, how we know who's a good candidate, and just sort of some of the effects we see overall. Feel free to let me know if you have any questions throughout. I'll try to answer them. If not, I will grab them at the end. Okay? Perfect. So we'll talk tonight about optometric light therapy and how we use it to improve our functional vision. So what is optometric light therapy? So it's known as Syntonics, it's known as optometric phototherapy, or optometric light therapy. The College of Syntonics, which is the group that really developed and uses this therapy often, they define the practice as Syntonics or optometric phototherapy is the optometric study and the application of specific frequencies of light applied through the eyes to rebalance the body's regulatory centers, thereby correcting visual dysfunctions at their source. And so it can treat a whole lot of different visual symptoms that we see. And a little bit about Syntonics. It was founded back in the 1920s by Dr. Harry Spittler. He actually wrote a book, I think it was published in around 1940. It's called the Syntonic Principle. So if you're interested in some of the science and some of the other things, I have a copy here. It's a good read just to understand a lot more of the thought and the science behind some of the lights. But he's the father of light therapy. He brought it to optometry and helps us understand just kind of how we've been using it in practice. So what he noted is that there was an imbalance between in the nervous system, the parasympathetic and the sympathetic nervous system. When one versus the other is more activated and we don't have that good balance, like in our top picture A there, we notice that we have, outside of just visual dysfunctions, just sort of overall all body dysfunctions and imbalances as well. Its popularity has waxed and waned over the years. When it was first introduced, it was pretty popular. People used it a lot, and then kind of more mid-century in the 1900s kind of fell off, and then in the more recent years, it's kind of picked up speed again. He began, and other people who practice light therapy began seeing success in treating strabismus, amblyopia, a lot of visual dysfunctions regarding convergence problems, focusing problems, accommodation issues, even learning disorders, and a lot of effects from stress and trauma. More recently, and how I learned to use light therapy was in our brain injury patients and even some emotional disorders. I've seen children who were on ADD or who were ADD, ADHD do light therapy as well, and just sort of help bring them back into balance and help with their learning. Okay, so how does this therapy work? So we use a specific color wavelength. So we call them filters, and the filters are certain colors. And depending on what color we use, it can bring the body's autonomic nervous system, back into balance. And again, autonomic nervous system here is our parasympathetic and sympathetic systems. The goal of optometric light therapy is to balance the autonomic nervous system, the system that controls our perceptual visual field, our functional visual field. We'll talk about that in a little bit. And we do that by, when the light enters our eye, it goes all the way back, stimulates our hypothalamus and pineal glands, which allows us to go back to our normal visual processing. What that brings us to is a state of syntony. Syntony being here meaning in harmony and in balance with oneself and the environment. So the process that we do this by is when looking at the light, the wavelengths help to stimulate the biochemistry of the brain, and that's done via the retinal hypothalamic system. So there are certain biochemical conditions in the brain that need to be present before we start to see these changes, new functions can occur. What the light does is help stimulate those neurotransmitters to begin that biochemistry, that biochemical cascade. It allows for additional synaptic connections to initiate that change, the growth towards healing. These colored filters are a very powerful tool to help stimulate that biochemistry of the brain. And again, that's through that retinal hypothalamic connection. So why light? The practice of using light in medicine and other healing processes has been around for quite a long time. And first used by the ancient Egyptian, Greeks, and Romans. You can find studies on, or their ancient writings that they use light in a lot of their cures. They even worship the sun for its healing properties. I think it's the Greeks. They even have a god of the sun, Helios. They named a city after him. So light was very important to these ancient populations, especially in healing. And then there's also indicated in both Indian and Chinese healers way back when, well, I didn't finish that, but they use a combination of herbs and the sun, and they helped a lot of skin conditions as well as other bodily function conditions as well. The first time we started seeing it more used in the modern world was from this researcher, Niels Finson. He learned that light has antibacterial and antimicrobial properties. So he's the one who kind of first found out that certain wavelengths of light here, UV light, help to kill bacteria. And even more recent studies have shown that certain wavelengths of light can help stimulate different parts of the body to heal and improve function. So that's called photobiomodulation. It's used in a number of healthcare settings, and it just excites molecules. It excites the mitochondria to have them work a little bit faster. So work faster, we increase their output, and it just helps healing overall. And they found that this works really well. So where else do we see light used in not just optometry, but medicine as well? So I can think of a couple. So here in optometry, this clinic is a dry eye clinic as well. We don't have IPL, the intense pulse light, but same idea kind of with, our iLux. We use light to heat up the glands, so light's used there. One of the more recent advancements in cataract surgery is the light adjustable lens. So I know that they'll use light rays to adjust how the implant, how people are seeing. I think it's a little bit of a process for them. They have to wear sunglasses and always have some special glasses on in the process of getting that exact prescription dialed in. But that's a place where we see light used in optometry. One that I use actually quite often, where we use lights and colors, is tints and glasses. Their studies show that our the FL41 tint, also known as the headache tint, that pink, that boysenberry tint, when a lot of our migraine patients, headache patients wear those lenses, it helps with some of their headaches. And the same sort of thing, lights coming in through that colored filter, it's helping that. So there's evidence all over optometry that light is very useful. And then even outside of optometry, we see it in dermatology and other medical fields as well. I know for dermatology, they'll use special light masks to help either kill bacteria or regulate the skin, helps with wrinkles and other sort of any sort of blemishes. So they use it there. Living up here in Pacific Northwest, I just experienced, I guess, my second full winter here in the Pacific Northwest. And, it's great. It's dark. I understand how people's moods change. The seasonal affective disorder is a real thing, and people use the happy lights here. So while not a certain filter color, we're still getting light to our system, makes us feel better, helps with the seasonal affective disorder. So there is studies here that, and there's, hard physical proof that light does help regulate our system. And again, mentioning the photobiomodulation, that's used to help healing, depending on if like even muscle aches and things like that. I know certain practitioners, maybe even in PT, they'll put a certain light on a certain area, and again, depending on the wavelength, it'll stimulate again the mitochondria and improve tissue function by decreasing inflammation, and it improves energy and just improves the output of those cells. And then another light thing here in optometry, I think this was maybe June or July of last year of 2020, is when the research came out about, can red light recharge the retina? Can red light bring back vision? And the thoughts behind that is the same thing with the biomodulation, that red light is just at that right frequency where we are getting those mitochondria to work a little bit harder, to increase their output, to work at the ideal level. And so the thought is that it brings back vision, or it gets the retina back to where it needs to be. So that's kind of the idea behind that. If you remember, when a lot of people were talking about that, it was just less than a year ago. But that's a sign of, or that's another place where we see light here in the industry. So going back kind of to some science basics, what is the autonomic nervous system? So it's part of the peripheral nervous system, meaning anything outside of the brain and the spinal cord. So it relays information to the rest of our bodies, the rest of our organs. It's what causes the unconscious control of the organs, what helps us breathe, what helps our heart pump, our liver and our pancreas to do their thing, any sort of reflexes like coughing, swallowing, sneezing, anything like that. So that's what it controls. And within that branch, it has two other branches. We have our sympathetic system and our parasympathetic system, which we all know, or we remember, is the sympathetic is our fight or flight response. So that's what sort of kicks us into gear, gets us moving. And then our parasympathetic system is our rest and digest, so keeps us calm, and just sort of, relax at our basal level, having our organs and everything else do the functions that they need to be doing. So we'll get into a little bit more of what each one controls here in just a moment. Okay, so again, we have sympathetic fight or flight on our right side, and then parasympathetic rest and digest here on the left. So important for us, the parasympathetic system, when that's kicked into gear, we have constriction of pupils, meaning we have accommodation, rest and digest. I'm sitting down, I'm going to read a book for a while, or look at my phone, read a tablet, and I'm using my accommodation. I'm in a parasympathetic state. Fight or flight, if I'm more on the alert, or if, suddenly, I'm sitting here reading a loud noise startles me, I'm going to look up, no longer have a constricted pupil, it's going to dilate. That way I can just take a little bit more in my environment, and I'm not kicked into my accommodation because I'm trying to look far away or just try and scan and see what's going on. So that's, for light therapy, that's kind of a big sort of key component there in telling what drives us, sympathetic or parasympathetic. And of course, we have everything else that goes on the parasympathetic side. We'll salivate, our heart rate will slow, our airways constrict. They're not dilated. We don't need to get a lot of air into our system. We're not rapidly breathing. So we'll start to digest. The liver and the gallbladder will be stimulated. Our intestines are running. And same thing on the other side, opposite on the other side. So if we're in a sympathetic drive, we're not salivating, we don't need to, digest, we're not eating. Heart rate increases because we need to pump blood to the rest of our body in case, we need to run away, something like that. Airways are relaxed, our bronchi are a little bit larger, we can get more air to the system. That's going to help reoxygenate the blood, pump the blood through faster since our heart rate's increasing. And we don't need to do anything with digestion. Stomach's not going, liver and gallbladder aren't putting out what they need to. Activity of the intestines just stops. And we do get a secretion in our adrenals, right on top of the kidneys, of epinephrine, norepinephrine. That's the molecules that sort of get us into this state and just sort of get us ready to go. So that is the symptoms. We like those to be in syntony. We want those to be in balance. And unfortunately, we see kind of one or the other sort of takes control, where if we remember that sort of seesaw picture at the beginning, we want it to be balanced, but sometimes we'll go one way or the other. And the goal of light therapy is to bring this all into that balanced state. So who can light therapy be for? Well, really anyone. Just sort of depends on your symptoms about when and what we would do for you. So it helps with strabismus, it can help with amblyopia, any sort of accommodation or focusing problems, convergence difficulties, even other sort of vergence difficulties, low ranges, any sort of just so asthenopia being just kind of any vague complaints. You can't quite really tell what's going on. It's just, it doesn't feel right. Things just don't feel the same. Things don't look the same. Vision attention deficit, even ADD, ADHD, it helps with that. Light sensitivity, headache or eye strain, that can sort of also tie into our accommodation problems. Brain injury, that's a big area here, and then visual consequences of stress or trauma, even if you think like stress syndromes in children or PTSD, things like that. Light therapy can really help out those folks who are struggling in this area, especially if you think about it: brain injury, PTSD, stress, any sort of attention deficit. You can probably think that their sympathetic side is really heightened. They're probably always in a state of fight or flight just because they've had something big happen to them, whether it be an injury, car accident, traumatic event. They're probably just always kind of on the edge of being able to really jump into that sympathetic state. So that's what we want to do with therapy, of course, is bring them back more into the parasympathetic side, or stimulate that side to get us more even. So in a lot of these, you can kind of tell that, yes, I see that one of those is out of balance. So once we see a patient, how do we decide that light therapy is for them, and how do we go about testing them? So a lot of the time it depends on what they're coming in for. For a brain injury patient, I always really dive deep into their symptoms. How is their sleep? How is their stress level? Do they have any light sensitivity? Sometimes in our brain injury exams, we try to run through our entire binocular vision assessment, but if you've ever worked with a TBI patient, you know that they can get tired out pretty quickly, especially if they've had a recent head injury or they're very symptomatic. So just even sitting and talking for the first 5 or 10 minutes to really get a picture of what happened to them, what they're feeling, that can tell me right then, oh, we need to do light therapy, or they're a good candidate for light therapy to start getting a jump on their symptoms. To help that. And so there's a couple different surveys or checklists we do. The brain injury vision symptom survey is a good one. The COVD quality of life, we have one here at our office that we kind of just picked and pulled some questions from, made our own questions, and so you can really sort of tailor it to how you want to approach your particular patient. The next thing we check, or another thing we check, and we do this in the exam room too, is the pupils. We look for what we call an alpha omega pupil. We'll go into that in just a little bit. But what an alpha omega pupil is basically how easily the pupil constricts and then dilates, how fast it escapes. Depending on how fast it dilates, that sort of tells us that we have one of our systems kind of in overdrive. So we'll do our entire BV assessment, and low ranges, inability to even complete the exam. Of course, if we see any strabismus or if we see any amblyopia, all that is signs that yes, you could benefit from light therapy. And then once we decide a patient's good for light therapy, we do a couple more very specific tests so we can decide what filter colors we're going to use, how much and how often we're going to do therapy. We use a gyroscope to check our Van Orden star. That helps us organize space. We'll talk about some of those in a minute and kind of what that looks like. We do a dynamic Brock string, which checks our range of binocular vision. And then we do what's called a functional visual field. It's very similar to your regular, our everyday visual fields, what we use to monitor glaucoma and then someone who's had a stroke or has any sort of field loss. But the functionality of the fields, so we test different colors and different forms, and we sort of get a map. That's what this guy in the bottom area there, and we'll go over kind of what those mean and what we're looking for and how what that tells us in terms of what's going on internally and how we want to treat that. So again, with the checklists, if there's any sort of concussion, we're going to want to do the brain injury survey, any sort of traumatic brain injury. If it's more of a learning disability, not doing so well in school, any sort of convergence insufficiency, accommodative problems, we're going to do the convergence insufficiency symptom survey, or even the COVD quality of life survey. If it's more of an emotional or trauma situations, kind of your call on if it's more PTSD, might want to do a brain injury, but if it's more like emotions, having trouble at school, that's overwhelming. Life is overwhelming. The quality of life might be a little bit better. But like I said, sort of tailor it to your patient. Or if you want to have an overall one where you pick a couple from one survey, if you pick a couple from another, write your own. That's a great thing about these is if you consistently want to check certain symptoms, you can write your own and have that for the patient, and that can give you a good snapshot into their world. So let's talk a little bit more about the alpha omega pupil. So what we're doing again is we're checking the the constriction and then dilation of the pupil. So all you need is to be in a dark room. So make sure the exam room door is closed, turn off the lights, and if you need to, almost like when you're checking anterior chamber for some of those cells and flares, even turn off the computer monitors. You're going to take a pin light, you want to take your pin light. You're going to have the patient look straight ahead. You're going to keep the light just on one eye, and you come up and you get real close and you shine it. You'll see the pupil constrict, and then you want to see that constrict in 1 to 3 seconds. If it takes a little longer to constrict, that could indicate an issue. And then when the moment it goes down and it stays down, you start counting. And it's good, like 1, 1,000, 2, 1,000, 3, 1,000. Give it a good second. What you're looking for is when the pupil escapes. Escapes meaning it starts to balloon out a little bit more. So it goes back into that dilated state. And so this chart here at the bottom, it tells you kind of our release times. So if we are able to get all the way to 10 seconds before it starts to escape, great. I don't need to recheck it and I'll take the light away. I'm not going to sit there for, holding the light at their eyes for 15, 20 seconds. It's pretty bright. It's uncomfortable for them. So I'm not going to put somebody through that. If we get to 10 seconds, excellent. That's going to be a good normal alpha omega pupil. Now, if we start to see it expand after about 7, 8 seconds, that's kind of like a trace to moderate pupil. So you can see here they grade it from 1 to 4, 4 being the worst, 1 being kind of there. And again, the less amount of time it takes it to escape, the worse your alpha omega pupil is. If you think about it, that's kind of like your sympathetic system being in overdrive. Sympathetic pupil dilates. So if we hold it, we want to see that constriction, but if we immediately blow back up, that tells us that sympathetic is kicked into overdrive. And so I hadn't really seen one before I'd never really looked for one before I started my residency. And then I started doing it on all my patients just to sort of check and see. And I could tell that some of my patients with binocular vision dysfunctions, pretty much all my brain injury patients had this alpha omega pupil where I would see it start to escape after 4, 5, 6 seconds, sometimes even less. So this is an excellent screener to know if your patient would benefit from therapy. This is kind of one of my keys of like, oh, yep, I definitely want to get them to light therapy. The only thing is, don't let it be confused with an APD. You should also at this point, yourself or your tech has already done pupils, and then you should be able to tell which is APD. And then, so that's the other thing about hippus. That's a little bit tricky. You'll see it go down, and then you might start to see it fluctuate like this, but if it keeps fluctuating where it's bigger and bigger, then we'll call that an escape. It takes a little bit of practice just to sort of notice it. So even if you want to see one and you're not doing light therapy or anything at your practice, but just try it on your next handful of patients, just if you can see kind of the difference between sort of just kind of going in and out and actually slowly escaping. So it is tricky, but practice tells you hippus versus actual escape. And then, of course, we do our full BV evaluation. This is all in the exam room. We check cover tests, we'll check stereo, saccades and pursuits, we'll check Worth 4 dot. That's really good at telling us if we have amblyopia, if we're seeing double, accommodative facility and MAM, check our accommodation system. I like to do a visual midline shift test, which just sort of checks, do people know where their center is? Some people think like, yep, center is right here. You do this test and you find out that people actually think their center is off to their right, off to their left. I see that often after concussions and any sort of brain injury, or if people are particularly clumsy, you sort of find that. After sports injuries, we can find that. Then, of course, we'll check phorias at distance, we'll check versions at distance, and we'll do the same thing at near. We do our FCC, NRA, PRA. And we look at all of this. If there's any sort of thing that's kind of off already, we know that we'll want to do some sort of therapy, whether it's vision therapy or light therapy or a combination of the two. Just having this information also helps us decide what sort of filters we're going to choose later. And then the next part we actually have our therapists do. So once we see a patient, we do their full BV exam based on symptoms and everything else. We're like, hey, I think light therapy would be good for you. And they say, let's do it. We send them over to our therapist and they do a couple more tests. They check the alpha omega pupil themselves. And then we have them do a VO star, which is done on a gyroscope. And so what that is it kind of has each eye seeing individually, and you start with one hand down low, one hand up high, and you just try to draw the lines until it looks like they meet in the center. And the way the prism and mirror are set up in here is that it looks like they are, but pencils don't actually touch. So this is an example of a perfect pattern. All these lines are relatively straight. We like to see that distance there to be about the distance apart is about 60, if I remember correctly. Anything more indicates an exo pattern. Anything less indicates an ESO pattern. But what it does is it's a visual pattern that helps us as practitioners gain insight into their binocular visual behavior. And so I'll show you a couple of examples in just a second of some abnormal behaviors, if we will. But it also tells us binocular posture, our ability to integrate vision and motor, and how we understand the world around us, organize our visual space, and just paying attention to our task at hand. So here's some examples of some VO stars that are, and I'll tell you what they look like. So this one here, this top one here is, in terms of distance, it's good, but the fact that it's kind of asymmetrical, the lines are kind of a little bit wonky. We see the left side just moves a little bit further in. This tells us that our patient has some errors in spatial judgment. This one where all the lines are kind of coming together. First of all, it's really close together. That indicates ESO posture. And the pattern is just, it symbolizes an unorganized visual world, especially that we're not coming kind of all to points like we are here. This top one here is an ESO posture because we see that it's closer in than these two marks there. The middle one, we see not only disorganization in space because all these points aren't coming together, but this is a definite vertical because we see that they're not in line here, but they're kind of offset. And this other one here indicates some amblyopia. This eye doesn't know what it's doing here, seen on the left. And so it's not aware of visual space and unable to sort of work in, we call this a problem with central processing too. So seen in amblyopia, seen in difficulties with central processing, but we just have these points not formed. So it actually gives us a really good insight into understanding the patient's, or how the patient understands their binocular world. We also have them do a dynamic Brock string and just an overall sort of functional vision range. So what dynamic Brock string is we'll have the patient hold the Brock string up to their nose. Therapist is on the other side. If they don't know, if they haven't done Brock string before, we teach them what we're looking for to see the X. And then after the patient gets the X, the therapist will pull the string. Patient keeps their head straight. They just move their eyes over until they lose the X. Either it slides off the bead or it disappears. That gives us our functional binocular range. We do it in both directions. And then they estimate the angle. So like, oh, we were out 20 degrees on the left. We were out 30 degrees on the right. And so we take a note of that. And then we also just sort of do functional peripheral. I have them use the vision disc just to sort of see, and I'll have the therapist mark down our range of vision this way. So that's what our Brock string shows us. And then I'll come back and I'll talk a little bit about what restricted binocular gazes might mean and how we see that pop up in other regions of our testing. So the last test we do, and this is one of the bigger ones for light therapy and how we judge how things are changing and improving, is what we call a functional visual field. It reminds me a lot of kind of our old tangent visual fields. I remember I just did it once in school for a lab just to say that I knew how to do it, but it's that black screen and it's got the rings, and the practitioner or the tester would bring a stick, and then the patient would say when they see it, the stick, and they would like put a little pin there and they would map out a visual field. It's like that, but it's a lot closer. It's right kind of in your at your working distance. So it tests your functional vision. Again, it's kind of that thought of just because you can see 20/20, that doesn't necessarily mean that you have perfect vision. So your brain might not be processing all the vision it needs to. It's a subjective examination of the sensory pathways, and it takes a look at our visual processing. There are two kind of things you've had doing this, or there's two different ways we do this. We have a actual setup here where there's like a piece of paper, and whoever's testing will actually mark on the paper. That's this guy here. They use little wands. The patient looks through there, stares at a center object, and then they say when they see it. And the therapist will mark that down. We use this more computer-based testing just because it's pretty nice for reliability and repeatability, and we have the patient's old files saved so we can sort of pull it up and see how things are changing. And this one, it can even be done by the patient, and the therapist just sort of monitors, or we can have the therapist do it for them. So it's just kind of a little bit easier, a little bit more portable tool. I'm going to go into ambient and focal processing because this does play into our functional visual field. You might also hear of it as magnocellular, cellular, and parvocellular processing, or central periphery processing. And so if we remember these cells in the back of our eyes, we have magnocells and we have parvocells. And so the magnocells tell us where. That's going to be most of our periphery. It's gross movement, or big movements, gross details, and it actually gives us information regarding balance, movement, coordination, and posture. And then our parvocells are our wet cells. They give us fine detail. They work on our central processing. They give us information when we're looking at an object. Most of these are derived in the macula. These two systems work in tandem, so we can keep focused on our central object, still being aware of our periphery, able to combine all of that in. When we see dysfunctions in our functional visual field, we have this ambient focal processing disconnect, magnoparvocellular cellular dysfunction disconnect. They're not talking. So this is kind of what's indicating any abnormality in the functional visual field. So what happens in this dysfunction is you are unable to tell where you are in space, and you have a difficulty processing what you're looking at. So can't tell where you are. I can't really tell what you're looking at. Your brain is having trouble bringing all that together. We can see this happen after a neurological dysfunction, so stroke, again, brain injury, anything like that. And you lose your ability to match spatial information with what you're seeing. That can lead to post-traumatic vision syndrome, visual midline shifts, and a lot of the same sort of symptoms we see in brain injury patients. These dysfunctions can also tie into reading and learning disabilities or difficulties if you can't process central peripheral information. I have a slide, and I have a couple slides in a moment that show kind of what that looks like if you're not able to focus central and peripheral, and how that sort of adds into reading difficulties. So our ambient processing is our higher sensory spatial interpretation. So if that's kind of out of whack, then overall our binocular vision system is just not going to work like we want it to. So we have a mismatch in space, and that's going to cause us to become clumsy and just unsure of ourselves. And that can lead to, again, some of those asthenopic complaints we'll get from patients. So what are functional fields? We test 3 colors and then a form. There are white, blue, red, and green. When we test these, what the patient does is similar to a visual field. They look into this machine and we go from seeing to unseeing. So there's going to be a target out in the center and it's going to move into their point where they can see, and then they'll say, I see it. And that's either when we mark it or we'll, click the button on the computer and it marks our seeing point. So we map 4 of those. We map the white, the blue, the red, and the green. And then we also measure the blind spot. We start in the blind spot area and we pull a target out until the patient sees it and we can map their blind spot. So what do each of these colors tell us? The white color tells us sort of contours of an object, the extent to which we can perceive movement. So really the largest that we can function, the largest we can see in our visual field, like how big our visual field is expanded. And then we move inwards in terms of colors. Our blue should be our next largest. What the blue color is it's tied to our heart and our circulation, our adrenal function. Any sort of abnormality here can be indicative of any psychological stress. The red, which is the next smaller one, is tied to the physical body and the major organs, so any dysfunctions there can cause the red one to sort of be out of whack, either a lot smaller, interlaced with the others. That is indicative of physical and structural strength, so any sort of problems there can cause our red circle to be a little bit different. And then the last one is green. That should be our smallest one. And that's tied to personal relationships, immunity, lifestyle, and another one is toxicity. So alcohol poisoning, any sort of heavy metals, things like that, that kind of shows up in our green circle. So again, that'll indicative of acute conditions and any sort of poisonings or toxins. So what do we see? So we just saw the normal field there, white, blue, red, and green. So what do we see when the blue is constricted? So like that picture there, that tells us, again, psychological stress. We can have energy loss due to any internalized tensions, indicative of headache or migraines, loss of an attitude, having learning disabilities, muddled thinking, poor reasoning, lack of self-awareness, and lack of any conscience. That's what's indicated with a smaller blue ring. When the red ring is constricted, that's more chronic conditions, fatigue, any sort of adrenal fatigue or dysfunctions, also related to reading difficulties, poor symbol recognition, uncontrolled emotions, so especially depression and grief, any sort of abuse, attachments to materials, even excessive appetite. So those sort of things tie into our red circle. And then the last one, when the green is really small and constricted, again, that's going to be the toxins, poisonings, any sort of affections, immune dysfunctions, and then emotions that relate to bitterness, grief, anger, loneliness, self-centeredness, or lack of forgiveness. So that's, again, sort of tying in that emotional component as well. So, and then we have the interlacing. So if the rings interlace, that, or if they overlap, that indicates any sort of binocular dysfunction or visual perceptual difficulties. Especially if the red and green are interlaced, we have a psychological or physiological imbalance, some sort of they suggest maybe like a blood poisoning of some sort, whether it's heavy metals or there's something not in balance. And then there's also if the blue and the red kind of overlap sometimes, this is down at the bottom, especially if the horizontal meridians are a little bit constricted, that indicates low fusional reserves. So you're going to see those base in and base out ranges be low. And then if they're overall constricted, all of them are really tiny right around the center. We have an overlap of almost all the colors, any sort of physical trauma, especially head trauma, so that brain injury or any sort of major emotional trauma, whether there was a big problem that happened in the family or a big move, something like that. Anything that sort of triggers that emotional state can show up there. And then high fevers and chronic illness can also cause a constricted field as well. So this was what I was talking about earlier in terms of how constriction fields or how a change in our functional visual field can affect us when we're doing reading and having learning disabilities. So if our field is compressed when we're looking at a page that we should see like this, make the print really small, hard to focus on, we can't really see that print because our entire field is just really compressed into space. or we'll get tunneling, which we'll be able to see the words, but only a little bit at a time. So especially if our saccades are off when we're reading, when we read, we take things in chunks and saccades. And if we have a really small area that we're working with, it's going to be really easy for those eyes to jump lines, jump words. We're not going to be able to see periphery, so we can see the next kind of set of words we're going to. So any sort of problem with our functional visual field can cause some reading difficulties as well. So this is an example of a before and after. Some light therapy. I think this person did it for about 2 weeks. This was in a study that was done by someone who uses the same tester that we do. But as you see, they kind of have some interlacing fields here when they first start. They have that nasal kind of constriction there, so low fusional reserves, interlacing rings, and then after 2 weeks of vision therapy, the rings look a lot better. We've got that green, red, and blue that we like to see, and they're nice and expanded. So we see a lot of improvement with the therapy there. All right, so now that we've collected all this data, let's put it all together. How do we do it here? So we'll start with the patient. We'll see them for our BV exam. Based on our symptoms and findings, we'll recommend light therapy. Patient sees a therapist, goes through all those tests. Therapist will gather that data, and based on that, we'll have a chat and we'll decide what colored filters we'd like to use. And then we send the patients home with an at-home syntonizer, and that's the device that delivers the light, the colored light for us. And the therapist goes over that with the patient and how to use that. So what we have the patient do is they take home our light unit. They spend anywhere from 2 to 10 minutes looking at a color. We'll give them up to 2 colors. Especially people who are a little more light sensitive may need to only start at 2 minutes, and then we can increase it to 10. And then we do that 3 to 5 times a week. And then after they do 20 sessions at home, we see them back. We recheck the functional fields, gyroscope, all of that, and then we see them back for a BV exam, see where our ranges are and how we want to proceed. Are we going to change colors? Are we going to keep the same and have them keep going? I would, after they do 4 full rounds, no matter where they are, if they're done, fantastic. If we still have a little bit more to go, just have them take a break, take a month off or 2, and then come back to it, just so we make sure that we're not overloading the system in terms of the lights that we're using. And so here's a picture of some syntonizers you can use. This main one here is an in-office one. In-office treatments are a little bit faster, a little bit more effective, but patient comes in almost every day and sits with this for 20 minutes. It's a lot easier for a patient to take it home. This bottom corner one looks a little bit more like our setup, what we send our patient home with, and they'll just stare at that filter for, again, 2 to 10 minutes, 3 to 5 times a week. Then there are companies that offer goggles that have the filters in them. And so what your patients do is sit in a dim room, wear the goggles, look at a light source, and they'll get their light that way. So it all sort of just depends on how the ease of which you want to do your therapy. So let's talk about what the colors are. The colors are named in the Greek letters, and they all have a specific role that they play. So alpha is red. That's going to stimulate our sensory, stimulates the sensory processing. Delta is more of an amber. That's a motor stimulant. Theta is a yellow. It's a very intense motor stimulant. Mu is green, and that's kind of our big equilibrator or balancer. Almost every color I prescribe, at least in the beginning, has mu in it at some point. Pi is a bright blue. It's a sensory depressant. Omega is a regular blue, more of a motor depressant. Upsilon is a really dark blue, an intense sensory depressant. And then we have a couple others here. We have a couple others here that we don't use quite as often, but they help really stimulate the depressant, stimulate the stimulant, or kind of really enhance our neurotransmission if we use those in combination with our other colors. So how do we choose what colors we want to use? If we have an acute syndrome, being recent head trauma, a stroke, any sort of loss of oxygen, anything like that, that's going to be an acute. So we have a protocol we do for acute symptoms. I'll show you what that is in a moment. And then we have chronic, so any chronic health problems, any lingering past trauma, learning-related disabilities, that all falls into the chronic. The the chronic key that we use. And then we have an emotional fatigue syndrome. So any sort of photophobia, blurred vision, especially while reading, any fatigue, any headache, that's going to fit into our emotional trauma colors. Then we have our amblyopia syndrome. So any sort of reduced acuity, if you have a head tilt or turn, poor depth perception, double vision, slow at reading, we have colors for that as well. The other thing we take into account in choosing our colors is if our patient is exo or ESO, and we know that from the exam itself. But also just think about their personalities. If you have a kid who comes in who's having trouble reading, they're very quiet, they're very within themselves, very reserved, that's going to be more of an ESO child, because you want to, ESO, we're turned in, you want to use a color to sort of lift them, bring them out. EXO, you have, again, if let's say it's another child who is having some problems with reading, learning disability, but they're bouncing all over your exam room, they're very excitable, they're eager to talk to you, very loud, has a big personality, that's more of an EXO kid. And so they're really out here, we want to sort of bring them in. So for EXOs, to bring them from out to in, we want to use our more depressant colors. And then ESO, we want to bring them from in to out. We'll use more of that stimulant color. And so what do I mean by kind of stimulants and depressants? So this is our tree, our pyramid that we use. As I said, mu is our great equalizer and balancer. That's kind of the basics of all of our colors. And then we sort of combine them based on if we want to do sensory and motor stimulant or depressant, and we go based on the pattern. So our acute conditions and our exos, so acute, again, being the brain injury, recent trauma, and everything else, brain injury, recent trauma, any sort of, I think I mentioned sort of like a hypoxia, things like that. That's going to be acute. We're going to lean towards more of the depressant colors here. And the depressant colors will calm down our sympathetic system, because when we think that sympathetic is in overdrive, we want to calm that down. That's also going to be for our exo patients, so the ones that are really out here, even XTs, we're going to use those colors. And then on the other side, we have our chronic conditions, so long-term trauma, any sort of long-term health conditions, and also our ESO posture, so the ones that are really quiet. In here, even our esotropia, we're going to stick more towards the stimulant colors, because we want to stimulate, because our parasympathetic is in overdrive, and we want to stimulate the sympathetic. So coming back to bring that all into balance. So again, our depressant colors, which are here on this side, is if our sympathetic system is in overdrive and we need to bring that down. So we need to balance it this way. And then our more stimulatory colors here on this side is going to bring us out of the parasympathetic state and again, bring us back into balance. So again, light therapy, it's all about finding that balance. It's kind of a little bit of an art to really choose what colors you want to use. But if there's a condition, we do have colors, we do have those filters for them, and consistently using them or using them as we prescribed, we can really see some really big changes. Some of my favorite patients to work with really are the brain injury patients. They tell me sleep is better, mood is better, and they just overall feel a lot better. And one thing you can do, I mentioned it just very briefly earlier on, is light therapy can either be done on its own or it can be done in conjunction with VT. When I would use it on its own is if I have a brain injury patient or a kiddo that's not ready for VT yet. Brain injury patient meaning way too symptomatic, let's start with colors to calm things down, or a VT kiddo who I don't think would do good in the therapy room just because they would be a little bit too much to control or not be able to sort of come out of their shell enough to really get some therapy done. But if we're able to do VT, light therapy will just make it a little bit easier and let us see some quick results. So that is kind of just a little bit about how we do it here at our office and what you're looking for in light therapy and kind of how it works. Are there any questions? I did see there was one I missed right in the beginning. Had some difficulty with the vision disc for vertical range of motion. Any suggestions how to prove measurement accuracy? I normally only do my horizontal ranges. For vertical range of motion, I don't use the vision disc for that, so sorry, I don't have any suggestions for you. What I do is initially I did have the therapist do vertical Brock string too to see where the X would break. to see if, what our kind of 360 binocularity range was. But they had some difficulty measuring it, and patients were a little bit confused on that. So I just stick to the horizontal ranges. But other than that, if there's any other questions, I'll hang around for a bit. Thanks for listening to me tonight and sort of opening up your horizons and just sort of listening a little bit more about about light therapy. I know it's kind of a newer topic and not always the most, people have some questions about it, but it's good that you're willing to listen and see how much it can really help patients. So thanks.
Sign in.
Oh.
With the link, tell them to sign in.
Oh, yeah, sorry. And then if you've been sitting through this, if you didn't see it in the chat box, we do have the link there. Go ahead and sign in, submit your information so you can get your credit. And other than that, I'll hang around for a little bit if anyone has any questions. And so thanks for listening to me tonight, and have a great rest of your evening.